Today we'll be teaching you about obsessive compulsive disorder, more commonly known as OCD. This presentation will go over the background and history of OCD, the signs and symptoms, the neurogenetic base of the disorder, and developmental course. And now here is a little bit of an overview of OCD. But before we get into that, I just wanted to help explain what people believe OCD is. Some people believe that it's organization. Some people believe it's being a germaphobe, needing to be on time, and about the way something is done. However, OCD is a disorder in which people have reoccurring unwanted thoughts, ideas, or sensations, called obsessions, that make them feel driven to do something repetitively, called compulsions.
Where did the term OCD originate? The 14th to 17th century. Records regarding obsessive-compulsive disorder date back to the 14th century. At that time, the term used was scrupulosity and was described more on a religious level. Saint Ignatius described obsessive doubting about pleasing God would lead an individual to being tormented by doubt and preoccupied rituals. Theologian John Dambach stated that many high-ranking people had become afraid of making decisions because of excessive scruples. In the 1600s, John Locke was the first mentioned physician and philosopher to discuss the subject and stated that the more an individual tried to suppress thoughts, the worse the thoughts became. At this time, doctors believed bloodletting was a way to treat symptoms and stabilize bad thoughts. In the 1700s through the 1800s, physicians started describing more symptoms such as obsessive washing and checking on things they had already taken care of. They also noticed fewer religious obsessions. In the 1800s to 1900s, psychologists were describing impulsive insanity, and OCD became the doubting disease. Wilhelm Greisinger published 3 cases of OCD and called it Grübelsucht, which is racking one's brain. In 1877, German psychologist Westphal termed the illness Zwangsvorstellung, which is compelled presentation or idea. This gave rise to OCD. In the 19th and 20th century, Pierre Janet stated that OCD came from the 3rd stage of psychasthenia illness, a neurotic state characterized by phobias, obsessions, compulsions that one knows is irrational and states this form of nervous energy interferes with an individual completing higher level activities. Sigmund Freud believed behavior is linked to unconscious conflicts manifested as symptoms, conflict between desires and subsequent actions of the conscious and unconscious mind, and stated that although patients know it's ridiculous to behave this way, they get temporary relief from it. In the past, health professionals saw this as a single nature illness, whereas today OCD is seen as a dual in nature illness, obsessive thoughts triggering anxiety, which leads to compulsion. Freud termed this Zwangs neurosis, which refers to anxiety neurosis. This term was still used in 1990s. London defines Zwang as obsession. New York defines Zwang as compulsion. Hence the term obsessive compulsive was born.
Now I will speak to you about the signs and symptoms of OCD, the behavioral and cognitive manifestations. OCD's sign and symptoms are having obsessions and compulsions. An obsession is repetitive and persistent thoughts, images, and impulses or urges that are intrusive and unwanted. A compulsion is repetitive behaviors or mental acts that an individual feels driven to perform in response to obsession to achieve a sense of completeness. These two combine control an OCD victim's life. Many children with OCD are not aware of these maladaptive behaviors. However, most adults are able to recognize them and report anxiousness and immense discomfort. Studies indicate 5 common sets of obsessions and compulsions in the patients with OCD. They consist of contamination, harm, unacceptability, symmetry, and hoarding. Here is a little chart that explains these in depth with the dimension, obsession, and compulsion. For example, if a patient had a contamination symptom, their obsessions would consist of just being really concerned about cleanliness, so dirt and germs, and their compulsion would be consistently having to wash, shower, or clean. Here is an example of a man who lives with OCD.
What I would do was basically, if I had to touch it to go like that, I would make sure the time was right, and then I'd be like 1, 2, 3, 4, 5, and then like, oh no, like a bone cracked or something, or I'm itchy, so now I gotta do it again. So 1, 2, 3, 4, 5, and now that's 2 times I did it, but 2 is a bad number, so now I gotta do it 3 times. So 1, 2, 3, 4, 5.
Harlan Kirschenbaum describes just one of the rituals that used to rule his life. For 13 years, he lived with an extreme case of obsessive-compulsive disorder, or OCD. It's a chronic psychiatric condition that has 2 main symptoms: obsessions, or intrusive unwanted thoughts that can't be pushed away, and compulsions, often called rituals, which are repetitive behaviors done to reduce anxiety.
My 2 obsessions are death and cancer, so I would come up with all these like crazy rituals. Like if I touched a wire, then I would think my brother would get cancer because of it. And everything morphed, and I got more and more rituals as time went on. And every day it seemed like I was adding a couple. I was housebound and I couldn't do anything for myself anymore.
At the height of his illness, Harlan had more than 100 daily rituals and couldn't touch or look at his family members.
I had thoughts like all the time of just like, driving into a wall or just anything, because I couldn't do it. It just took all my energy out. Like I'd be crying in public, and 30 years old, and I'm sitting there crying because I saw a traffic light, and now I think that I'm gonna give somebody cancer because of it.
Okay, so now we're on to the neural and genetic basis of OCD. As far as the neural basis of OCD goes, an enormous number of neuroimaging contemplates high practical and primary adjustments in the corticostriato-thalamocortical hardware. In particular, useful overactivity in the anterior cingulate cortex, the orbital frontal cortex, and the basal ganglia may interfere with cognitive functioning and subsequently with execution during dynamic and learning in OCD. A few examinations have analyzed the improvement of manifestations of OCD after cerebrum injury. Damage to the basal ganglia, particularly the caudate, the OFC, and the ACC, are related with the obtaining of OCD indications following mind injury. Dysfunction of the basal ganglia secondary to a streptococcal contamination or encephalitis lethargica has likewise been related to the advancement of OCD side effects. So for the genetic basis of OCD, OCD is a complex genetic disorder with unknown genetic and environmental basis. Genetic influences of moderate impact are likely to be widespread, possibly in addition to other less common genetic factors. And many of these genetic determinants are unlikely to have been identified using conventional methodologies of linkage. In addition, the biological basis of OCD is largely unknown, and in particular, metabolic pathways prevent a more focused genetic search. So the actual neural and genetic causes of OCD are still unknown to this day, but there are 3 theories of causation for OCD. The first one is biology, meaning that OCD may be a result of changes in your body's own natural chemistry or brain functions. The second one is genetics, meaning that OCD may have a genetic component, but specific genes have yet to be identified. And then lastly, learning, meaning obsessive fears and compulsive behaviors can be learned from watching family members or gradually learned over time.
Okay, now we're going to talk about the developmental course, the risk factors, and the treatment. The risk factors that increase your likelihood of getting OCD is genetic predisposition. So having a parent, sibling, or child who has been diagnosed with OCD increases your chances that you will also be diagnosed with the disorder. Neurological causes. Some brain imaging research has noted differences in parts of the brain structure, including the frontal cortex and subcortical structures, between people who have OCD and those who don't. So there appears to be a connection, but that connection is still unclear. The next factor is environmental factors or stressful life events. So research has shown a connection between a history of physical or sexual abuse in childhood and the development of OCD. And other childhood traumas may also be a risk factor for the development of the disorder. The reactions may trigger intrusive thoughts that lead to developing the rituals. The last one is bacterial infections. So some children develop OCD or symptoms consistent with OCD after having a streptococcal infection. There's this pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections, otherwise known as PANDAS. So when it comes to diagnosing OCD, there are 3 steps taken. The first one is a psychological evaluation, which is like a therapy session, including discussing thoughts, feelings, and symptoms while observing behavioral patterns. The second one, they're going to check the criteria that could be used from the Diagnostic and Statistical Manual of Mental Disorders, otherwise known as DSM-5. And the third one, a physical exam could be done to rule out any other problems that could be causing these symptoms. Remember that OCD is sometimes difficult to diagnose due to similarities in symptoms that have to do with other mental health disorders. It is also possible to have OCD along with other mental disorders. Last, the treatments for OCD. So there is psychotherapy, which includes cognitive behavioral therapy and exposure and response prevention. CBT focuses on challenging thoughts and behavior patterns to help change the direction of the behavior or take it out altogether. And ERP is a component of CBT. It involves gradually exposing you to feared subject or obsession and having you learn to resist it. The next treatment is medications. So you can take antidepressants, antipsychotics, or other meds, e.g. holistic herbs. The meds approved are Anfranil, Prozac, Paxil, and Zoloft. You should consider these side effects when choosing to start or change meds. Also, remember, treatment may not result in a cure. However, it can help keep symptoms under control. Also, treatment is often most effective with a combination of both of these. Please speak to your doctor to see which route you could best proceed forward with.